Yes, Priyadarshini, you can start now.
Yes, sir. Hello, my dear nursing students. This is Priyadarshini, your mastermind faculty at Nursing Next Live. I welcome you all to the prediction series where we are going to discuss some of the most important topics which can be probably asked in your upcoming NORCET examination. Right? Yes, a very good afternoon, everyone. Please share in the chat box whether my voice is audible and the screen is clearly visible. Yes, yes. So this month is a very, very important month. You have your upcoming NORCET examination, prelims, and April 11, and you are all set up in a lot of fire for your upcoming examination. So this period is very crucial. You have put all your hard works, and this is the time where you have to critically utilize and analyze and strategize how you're going to approach the examination so tactically, right? So to approach the exam tactically, MCQ practice is one of the important key concept. So along with the important topics which we are going to learn, we are going to learn some of the key important skills which you have to utilize while you're attempting an MCQ, right? So it's not like within one session we can maximize the MCQ attempting strategy, but it comes with practice, right? So I'll open one MCQs and you have to actively participate in answering those MCQs, right? Yes. So the first question which we're going to see under our adult health nursing. So for the diagnosis of resistant hypertension, the patient should have uncontrolled hypertension despite taking 3 antihypertensive drugs, right? So this should include at least one. So when you're telling a patient is a case of resistant hypertension, wow, very good, Parvesh. Hearty congratulations on your victory of getting 82nd rank in RRB. Very good. Yes. Now tell me what is mean by resistant hypertension. So classically, resistant hypertension is defined as whenever greater than or equal to 3 classes of antihypertensive medications or becoming resistant. And even after that also, the BP is not falling and it is remaining above 130 out of 80. Then you're telling it is resistant hypertension. Very good. Anshika has given the answer. It is diuretics. Yes. So now tell me what are all the 3 classes which comes under this resistant hypertension related categorization. So first is your AC inhibitors, as you all know, and ARB, angiotensin receptor blockers. Right. So AC inhibitors and angiotensin receptor blockers both comes under the category of what? Renin angiotensin aldosterone system blockers. Right. So these both are coming under RAS blockers. Right. Along with that, we are going to give what? Calcium channel blockers. Right. We are going to give calcium channel blockers also. And the most important part is diuretics. Whenever we tell it has resistant hypertension, it is the problem with the fluid overload or the volume overload. The problem is what? Volume overload purely here. So why volume overload is happening? Why we are giving RAS blockers? See, the primary killer here or the primary pathology behind this resistant hypertension is your aldosterone. Right? What happened to aldosterone here in resistant hypertension? I want you to actively put in the chat box what happens to aldosterone in case of your resistant hypertension. Aldosterone is increased here. That's why first we are giving AC inhibitors, angiotensin receptor blockers, then calcium channel blockers. After giving calcium channel blockers, we are going for diuretics, specifically thiazide diuretics we are going to give. So here also we have an important MCQ. So specifically the first line we are giving thiazide diuretics in order to reduce this volume overload. If at all the GFR is going to be less than 30, now tell me, if at all the GFR is going to be less than 30 ml per minute, then what will be the diuretic of choice? Very good, Anshika. Aldosterone get increases. Very good. So coming back to the diuretic component, the primary diuretics which we are using in case of hypertensive patient is thiazide diuretics. So once thiazide diuretics we are using, what are all the limitation? If at all the GFR is less than 30 ml per minute, thiazide diuretics will not have a proper efficacy, right? Thiazide diuretics will not work in that case. So at that time, for what diuretics we are shifting? We are shifting to loop diuretics. So when the GFR is less than 30 ml per minute, so in this case, we are going for what? Loop diuretics. Example is your furosemide, right? So when the GFR is reduced, loop diuretics is going to work effectively in that condition also. That's why we are taking loop diuretics, right? So coming back to the aldosterone. So what is the primary mechanism of aldosterone? Aldosterone causes sodium and water reabsorption, as you all know. Yes, very good, Parvesh. Right? Sodium and water reabsorption and potassium excretion. And potassium excretion, this particular aldosterone is doing. Whenever the BP is falling, this renin angiotensin aldosterone mechanism is activated and aldosterone is produced, and it is producing its activity. The primary action of aldosterone is what? Sodium and water reabsorption and potassium excretion, as many students are actively telling in the comment box, right? So whenever we are telling aldosterone is doing this particular mechanism, when it is hyperactive, when aldosterone is produced in larger quantity, what is going to happen? This particular process is also going to get higher and higher and higher, which means excessive sodium and water will be accumulated in the body and excessive potassium will not be excreted, right? Sorry, excessive potassium will be also excreted, right? So next is resistant hypertension. So this is the primary pathology where the aldosterone is going to get increased. Because of that, volume overload is happening. And to override this volume overload, the last option we are using is diuretics. If at all after diuretics also, the patient's resistant hypertension is not overriding, then we are going for what? Spironolactone. Some students have already answered. Like spironolactone is the drug of choice for resistant hypertension, right? Once the patient is given with AC inhibitors, ARBs, calcium channel blockers, then diuretics, even after that, the hypertension is not resolving. It is remaining above 130/80. Then we are going for what? Spironolactone. And spironolactone is considered to be the drug of choice of your resistant hypertension. This is again a very, very important point that you people have to note, right? So when a person is not responding for 3 antihypertensive drugs, we are classifying him as an antihypertensive, like as an resistant hypertension. And if they are asking an MCQ, what is the drug of choice in case of resistant hypertension? Then your answer should be what? Spironolactone. Or if they're going to ask you fourth line medication for treating such patients, in that case also you have to answer spironolactone only. So talking about beta blockers. So what is this beta blockers? Beta blockers are basically what? Rate controllers, right? So they reduce the heart rate and they try to reduce the cardiac output also, right? But they do not address any form of volume overload. Beta blockers are not helpful in volume overload related mechanism. So what about alpha blockers? So alpha 1 blockers, specifically your prazosin, your doxazosin, your terazosin, these drugs reduces the peripheral vascular resistance, but does not involve actively in reducing the volume overload. Here, the primary pathology in resistant hypertension is increased aldosterone. So the primary intention is to override this volume overload, right? So that's why we are going for diuretics as the correct answer in this particular MCQ. But if they are asking about the drug of choice, then your answer will be different. That is your spironolactone. right? And the another MCQ which you have been studied is when the GFR is reduced to less than 30 ml per minute, at that case, the diuretic change should be there. In spite of thiazide diuretics, we are going for loop diuretics, right? So let's go for the next MCQ. A 28 years old man with a history of recurrent headaches, okay, with a history of recurrent headaches, comes to the OPD with an acute episode of headache lasting for less than 30 minutes with redness and watering in one eye. Okay, so they are telling redness and watering in one eye. So you have to come to the conclusion that it is unilateral. So which of the following is not used in the treatment of an acute episode of patient? So here, while I am reading this particular MCQ, I am just stressing the important key pointers, but no one will stress the important key pointers while you're sitting in front of the monitor in your AIMS not set, right? Yes, very good. The acidius. Yes. So she has given the correct answer. The correct answer is verapamil, but I want the justification. Now tell me, what is the diagnosis of the patient in this case? What is the diagnosis of this patient? He is having a history of recurrent headache, right? So he's coming to the OPD on an acute episode of headache again, right? And which is lasting less than 30 minutes only. And he also have this unilateral redness and watering in one particular eye. What is the most, which is not used in the treatment of acute episode? So yes, very good. So verapamil, when you people are rejecting, because we are telling it is not used in the treatment of acute episode. Verapamil is a prophylactic drug, but it is not effective in case of acute setting. Yes, give a big round of applause to Anshika. The diagnosis here is cluster headache. The diagnosis here is cluster headache. So what is cluster headache? Cluster headache are always unilateral, okay? And you will be having this unilateral periorbital pain, and the duration of the headache is very short. Okay, it can last for 15 to 180 minutes, which means for up to 3 hours they can last, okay? And that is the component behind here. And most important concept in cluster headache is they are always associated with the what? Autonomic features. Okay, autonomic features include your lacrimation, conjunctival redness, okay, nasal congestion, rhinorrhea. So these kind of symptoms you can see in a patient with a cluster headache, right? So these cluster headache is stimulated by what? Which is activating this cluster headache? This is stimulated by your posterior hypothalamus, right? Cluster headaches are stimulated by your posterior hypothalamus, which is proceeding with lot of this particular autonomic symptoms. So next we are going to talk about the distractors. As I said, verapamil is a prophylactical drug which is used for cluster headache. Okay, it is a drug of choice in case of cluster headache prophylactically. But in acute settings, definitely we are going to use this nasal sumatriptan, right? So sumatriptan, what it is going to do? Anybody in the comment box? Very good. Sumatriptan, what it is doing? So intranasal sumatriptan, if you're going to administer, okay, it is the 5-HT1 or B1 agonist. So this is going to cause vasoconstriction of the dilated intracranial vessels, right? They're going to cause vasoconstriction of dilated intracranial vessels. The most important point, right? The primary action of the triptans, the sumatriptan, right? So they are going to cause vasoconstriction of the dilated intracranial vessels. Thereby, they are effectively reducing this cluster headache, right? So what about the sumatriptan subcutaneous? It is going to be even more faster onset of action. Okay, so nasal sumatriptan will act within 30 minutes. It's going to act within 30 minutes. But when we talk about subcutaneous sumatriptan, okay, it is going to be even more actively working better when comparing to your what? nasal, right? So this is also having the same action, right? It is going to cause vasoconstriction of the dilated intracranial vessels, right? So what about this 100% O2? Obviously, this is also one of the important management while managing the patient with a cluster headache, right? We are going to give 100% O2. With what media we are going to give? We are going to use non-rebreather mask. Okay, we are going to use non-rebreather mask, okay, at the rate of 12 to 15 liter per minute. Okay, that is going to cause an immediate action and relief from this particular what? Cluster headache, right? The most important and effective and safest mode of acute management is your nasal sumatriptan, subcutaneous sumatriptan, and 100% O2 delivery, right? So they all are going to do the similar actions. Thereby, we are going to get override from this particular condition, right? So now tell me the differentiations between your cluster, migraine, and your tension headache. Cluster headache, just now we have studied clearly, okay? Severe stabbing, periorbital pain, and unilateral features you can see, okay? And it is completely unilateral. What about migraine? What about migraine? What about migraine? Migraine also usually it is unilateral only, right? In most of the cases. What about tension headache? Tension headache is bilateral always, right? So what is the duration? This happens for 15 to 180 minutes, as we have already studied. What is the duration of migraine? It is 4 to 72 hours. It can last for 4 to 72 hours, right? And what about your tension headache? This can last for 30 to, this can last for 32. Once again. Once again, the pen is not writing. Just give me a moment. Okay. So now the pen is writing. Sorry for the inconvenience. Yes. So now we're going to talk about the tension headache's duration. So what is the duration of tension headache? Like it can last for 30 to 7 days, 30 minutes to 7 days. It can last for 30 minutes to 7 days, right? Yes. And what is the autonomic features in cluster headache that we have already seen? That is lacrimation, lacrimation, ptosis, and congestion can be seen. In case of migraine, you can see nausea and vomiting. In case of tension, like in most of the cases, You don't see any major symptoms, right? Autonomic symptoms. What are the triggers? For cluster headache, alcohols, like cluster period, or can be the triggers. In case of migraine, hormonal triggers, light triggers, or food triggers can be possible. In case of tension, stress, and poor posture can be the reason for tension headache. The most important thing that you have to learn here is, in case of acute management in cluster headache, just now we have seen O2 and your sumatriptan, right? And in case of migraine, here also in acute setups, you're using triptans and NSAIDs, right? Non-steroid anti-inflammatory drugs. In case of tension headache, for acute setting, we are using paracetamol and your NSAIDs, right? So for exam point of view, prophylactical management. Prophylactical management here in cluster, it is verapamil. In migraine, this is very commonly asked question, that is your propranolol, right? Your propranolol, very good, right? In case of your tension, amitriptyline is the drug of choice, right? Your amitriptyline is the drug of choice, right? So this is the important points you have to remember, right? So let's next go to the next question. Yes, ABG questions are always expected in your examinations, right? So this becomes an high yield question also. A 60 years old man with a history of chronic obstructive pulmonary disease. With this itself, you should come to the conclusion like what will be the expected ABG finding, right? And you can see he is present with increased shortness of breath, which means hypoventilation. Very good. Many students are very actively answering the ABG questions. Certainly, you are interpreting very good, right? So I'll ask some crucial questions. You people have to answer for that also, right? So his ABG analysis is shown what is the most probable underlying acid-base disorders. So active students have already said the answer. The answer is respiratory acidosis. So whenever you see a COPD patient, you have to understand the patient will be going for what? Hypoventilation. Hypoventilation happens because of what? In COPD, you will be having airflow obstruction. So when there is an airflow obstruction, right, the patient will be going for hypoventilation, which means when the patient is going for hypoventilation, when I'm so passively hypoventilating, what will happen? Lots and lots of amount of carbon dioxide will be accumulated in my lungs. When excessive carbon dioxide is retained, CO2 retention is there. Excessive CO2 retention is there. As I said, you CO2. Okay, this is an acid component. Okay, your carbon dioxide can form an acid component, that is your what? Carbonic acid, right? That can form what? Carbonic acid in association with the reaction. So this is forming carbonic acid. So when carbonic acid is excessively accumulating in the body, the patient will be going for acidosis. Okay, very good. CO2 retention is preceding the patient to go for acidosis, right? So this is an important component you people have to remember. Whenever the patient is going for hypoventilation because of excessive CO2 retention, it will react and form carbonic acid. Carbonic acid is an acid component. The patient will become acidotic. Okay, the pH will form. So obviously, a COPD patient will be going for a respiratory acidosis. This is a well-known concept, as you all know. So let's solve this with the help of this ABG finding. So here we have the pH of 7.24. The normal pH, as you all know, it's 7.35 to 7.45. So here it is 7.24, which means the pH is reduced. So the PaCO2 here, the PaCO2 is 60 mm of Hg, right? The PaCO2 is what? 60 mm of Hg, which means it is elevated. The normal PaCO2 is 35 to 45 mm of Hg. Right. So what about the PO2 here? PO2 is 52. The normal PO2 is, okay. So the normal PO2, you're not going to utilize majorly on diagnosing the ABG. Please just ignore. So next is HCO3. So what about HCO3? HCO3 normal value is what? 22 to 26. So here you can see the mild elevation in HCO3. That is a very mild elevation in HCO3 you can see. So for the new learners, like what is the easy way to learn ABG, or when you see in the paper without any confusion, how you can draw the conclusion what is the finding is when pH and PCO2 goes in same direction, right? If pH increases, PCO2 also increases. If pH decreases, PCO2 also decreases. Then they are going in same direction. If they are in same direction, then it's going to be what? Metabolic problem. Okay, remember the same CM, and it is a metabolic problem. When pH and PCO2 is going in reverse direction. Yes. When pH is increasing, PCO2 is decreasing. When pH is decreasing, PCO2 is increasing. Then it is going in reverse direction, right? So when they're going in reverse direction, remember this reverse R, it is going in what? Respiratory problem. So here we can draw the conclusion. You can see the pH is going down and the PCO2 is going in the upward direction. pH is decreasing and PCO2 is increasing. So obviously it is a respiratory problem, and you can come to the conclusion whether it is acidosis or alkalosis with the help of pH. When the pH is increasing, remember Hulk. pH is increasing, it is alkalosis. When the pH is decreasing, it is acidosis. Right? So that's why we have come to the conclusion, and in close correlation with the COPD. Whenever the patient is a case of COPD, because of airflow obstruction, he is going to go for hypoventilation. When there is hypoventilation, the lungs is not exchanging CO2 properly. So excessive CO2 retention will be there. If excessive CO2 retention is there, CO2 is going to do the mechanism and it is going to get converted into the carbonic acid. So carbonic acid is an acid component, which is leading to the reduction in the what? Reduction in the pH because of acidosis, right? So this is how you have to draw the conclusion for this particular question. So with the use, like definitely you will get ABG related MCQ. So it is very, very important to learn this, right? So now tell me, in what are all the cases you can see this metabolic acidosis? Examples of metabolic acidosis. Very, very good evening. Right? Tell me, in what are all the cases you can see the patient with metabolic acidosis? Metabolic acidosis will be seen in case of what? In case of your diabetic ketoacidosis, right? In case of your DKA, diabetic ketoacidosis, right? In case of renal failure, classical finding of your renal failure, very good, very good. And in case of your lactic acidosis, also, you will get your metabolic acidosis related findings. Sometimes when you're stuck in interpretation, you can able to correlate with these conditions, right? DKA, renal failure, lactic acidosis are the most common examples for your metabolic acidosis, and that are the most common causes for causing metabolic acidosis, right? So tell me, metabolic alkalosis. So in which are the cases you can see metabolic alkalosis? What are the common causes for metabolic alkalosis? Yes, very good. Vomiting. Vomiting is going to cause excessive acid excretion through vomit. So the patient will go for alkalotic state because of acid loss, right? Then in case of your diarrhea, in case of your diuretics, in case of your diuretics administration, you can see the patient going for metabolic alkalosis, right? On the other hand, in case of hyperaldosteronism, right? In case of your, I'm using a different color, hyperaldosteronism, the patient can go for metabolic alkalosis. What about respiratory alkalosis? When you tell in respiratory acidosis, hypoventilation is the reason. In respiratory alkalosis, hyperventilation will be there. So hyperventilation, which means excessive CO2 washout. Excessive CO2 washout, CO2 is an acid component, right? CO2 is an acid component, as you all know, right? So when CO2 acid component is excessively washed out, the patient will be going for respiratory alkalosis, right? So what are the cases? Hyperventilation in case of anxiety, where the patient is getting hyperventilating, okay, rapid breathing he's doing, right? In case of early sepsis, these are the common examples where you can get MCQs from this particular topic. So that's why I'm explaining this, right? In case of anxiety, in case of early sepsis, the patient can go for very good, respiratory alkalosis, right? This is a very, very important component, and definitely you will get an MCQ from ABG. There is no more second thoughts in it, right? So now tell me your Chostic and Trozzi sign is seen in case of alkalosis or acidosis. Any active students? We have your Chostic's and Trozzi sign, right? Which you see in case of hypocalcemia. That you will see in case of alkalosis or acidosis. Yes, I'm waiting for your answers. Yes, very good. It is seen in case of hypokalemia. Very good, very good. In case of alkalosis only, you can see this pH is increasing higher, and you can see the signs of hypocalcemia. Very good, very good, very good. So we're all already set to go for the examination, I think. Yes, very good. Yes, the next question. Very good, very good, very good. Very good, Shaki. Very good, Saki. Yes, yes, yes. Very good, very good. So the next question, a 68 years old male admitted to ICU for acute exacerbation of COPD. So whenever you see an word acute exacerbation, remember, suddenly the patient has got, the symptoms got increased, right? For example, suddenly the patient is having dyspnea. Okay, this dyspnea is causing hypoxia and hypercapnia, right? So that's it. That is what, and coughing also the patient is getting so suddenly, the symptoms are getting increased. And if at the time of acute exacerbation, if the patient is not going to be treated properly, the patient will go for worsened aspects. The prognosis will be very poor. Very good, very good. Yes. So here the following ECG changes are seen in. Whenever you see the COPD's association with the particular ECG finding, yes, it is your multifocal atrial tachycardia. Now tell me, what is the definition of your multifocal atrial tachycardia? This is the correct answer, as you all said. Right. What is the definition of multifocal atrial tachycardia? Remember, this is an irregular cardiac rhythm. As I said you, it is an irregular rhythm. Right. And the classical definition, how you are telling the ECG that it is a multifocal atrial tachycardia. Okay. So when the P wave morphology, okay, when the P wave morphology is different P wave morphology of greater than or equal to 3, morphology is different. So then you're coming to the conclusion, the patient is a case of what? Multifocal atrial tachycardias. Like greater than or equal to 3 distinct P wave morphologies you can see in a single lead, For example, here we will take lead 2. So lead 2, you can see the P waves here. See the P wave morphology, how it is differing, right? So this is called as your multifocal atrial tachycardia. So why we are telling COPD is associated with MAT, right? Why COPD is associated with MAT? So in case of acute exacerbation of COPD, as I said you, the patient will be going for sudden dyspnea, like coughing and all the effects. So when they're going for sudden dyspnea, coughing and all these effects, the patient will go for hypoxia, which is associated with hypercapnia. So when hypoxia and hypercapnia is happening, the patient can go for sympathetic activation. So when sympathetic activation is activated with respect to this hypoxia and hypercapnia, the atrial stretch can happen. What will happen? The atrial stretch happens because of sympathetic activation, right? Atrial stretch is happening. So because of this atrial stretch, because of this atrial stretch only, multiple atrial foci, ectopic foci, where COPD causes hypoxia, hypoxia is going to stimulate sympathetic activation. Sympathetic activation is stimulating the atrial stretch. When the atria is stretching, this is going to create multiple ectopic foci. Ectopic foci. Right. This is leading to this what? Distinct P wave morphologies, which is greater than or equal to 3. Right? Yes. So this is the ECG of your what? MAT, that is your multifocal atrial tachycardia. Now tell me classically, what are the findings of ventricular tachycardia? In ventricular tachycardia, you're going to see wide QRS complex, okay, which is going to be greater than 0.12 seconds. Okay, wide QRS complex is a classical feature. Atrial fibrillation, what is the case? Atrial fibrillation is an irregular rhythm. As you all know, it is an irregular rhythm and there will be no visible P waves. Okay, P wave will be replaced by the fibrillatory waves, right? You can see in the ECG classically. And what about atrial tachycardia? Atrial tachycardia, you will be having a single morphology P wave, right? P wave will not have different characteristics. P wave will be similar only. Okay, but you can see a tachycardia which is associated, right? And I'm telling if there is greater than or equal to 3 distinct P wave morphologies, we are telling it is multifocal atrial tachycardia. So what if it is less than 3 distinct features? What is the term if there is only less than 3 P wave morphologies or distinct features? Any people can answer me? If it is less than 3, what is the term? Then we are telling if the atrial foci is happening and that is showing only less than 3 P wave morphologies, then you have to remember it is wandering atrial pacemaker effect, right? It is wandering pacemaker effect. Okay, atrial pacemaker effect to be very specific, right? So, or you can tell it is an atrial tachycardia, which is having only single focus. Okay, only single foci is creating this abnormal finding, right? Yes. So now tell me, what is the management of MAT? What is the management of MAT? Multifocal atrial tachycardia. What is the management? Anybody in the chat box? Anybody in the chat box? Yes. So remember, first is to treat the underlying causes. Okay, hypoxia, hypercapnia, and electrolyte imbalances. So when they are asking an MCQ, which of the electrolyte imbalance are closely associated with your MAT? Then your answer should be magnesium and potassium, right? We have to correct all these impairment in the electrolyte imbalances, and hypercapnia and hypoxia has to be created. That is the baseline. Then we have to go for very good, Pooja. We have to go for brampamil or diltiazem. That is the calcium channel blockers. Okay. Then we are going to go for calcium channel blockers, right? The important key pointers which you have to remember is very good, right? The important key pointers which you have to remember while studying about your multifocal atrial tachycardia is when there is 3 or more P wave morphology, distinct features, then you're telling it is a multifocal atrial tachycardia. And you have to remember this particular concept also. Whenever the rate is greater than 100. The rate should be what? Greater than 100 beats per minute. This is also you have to remember, right? So next, we will go to the next question. A 40 years old woman with a history of multiple sclerosis comes to the hospital. She describes an electric shock-like sensation radiating down the back into the leg. What is the name of this sign? Yes, come on. Give me your answer. Yes, suddenly people started giving answer. Yes, it is your Lehermitz sign. Right? So multiple sclerosis is closely associated with this Lehermitz sign. Okay, this is because of the demyelination of the axons, right? As you all know, in multiple sclerosis, demyelination of axons happens. So when it is specifically happening in the dorsal column, okay, this dorsal column demyelination, very good. Axon in the dorsal column going to cause hyperexcitability of that particular column. Okay, that is going to cause hyperexcitability. When there is an hyperexcitability, what will happen when the neck is mechanically flexed? Okay, this particular hyperexcited state of your dorsal columns, they're going to produce a potential action potentials, right? They're going to produce some action potentials, and this action potentials is going to give this particular flickering effect of electric shock like effect, right? That is called as your Lehermitz sign, which is classically seen in case of multiple sclerosis. And this Lehermitz sign can also be seen in some other condition also. Okay, it is associated with multiple sclerosis. Can you people tell me in what other conditions you can see Lehermitz sign? This can be seen in other conditions also. For example, in case of your cervical spondylosis. Okay, in case of your cervical spondylosis. Okay, in case of your radiation myelopathy. Okay, in case of your radiation myelopathy. In case of your vitamin B12 deficiency also, okay, vitamin B12 deficiency also, you can see the patient with Lehermitz sign. Okay, this is purely happening because of what? This demyelinated axons or stimulating the dorsal column to become hyperexcited. And this hyperexcitation is creating an action potential, which is causing this electrical shock-like effect, right? Yes. So you have to remember, it is not only seen in case of multiple sclerosis. It is seen in case of multiple sclerosis, along with other condition, which includes your cervical spondylosis, radiation myelopathy, and your vitamin B12 deficiency. Now tell me, what is this Uthoff phenomenon? What is Uthoff's phenomenon? Anyone in the chat box? Yes. Uthoff's phenomenon. Yes. Uthoff's phenomenon is the concept where when the patient is exposed to excessive hot temperature. Okay, for example, the patient is a case of multiple sclerosis and he is having this fever, and he's exposing to hot bath, or he's doing a rigorous exercise. At that time, what will happen? His temperature will get elevated in his body. When this elevated temperature is there in the person's particular body, here what is going to happen? This is going to impair the conduction in the demyelinated axons. So when there is an impaired conduction in this demyelinated axons, this is going to produce this worsened symptoms of that particular disease condition. So how to override this? Overriding this is simple. Like when you're going to reduce the exposure of excessive heat, the symptoms will subside, right? So next is your Strangke sign. What is Strangke sign? Strangke sign is also a concept behind your Babinski sign. Okay, Strangke sign is a plantar reflex sign. Okay, that is used in the neurological examination. It is a plantar reflex sign. So how you are going to do this particular examination of the sign? Okay, we are going to pull the little toe. Okay, little toe laterally. Okay, of the little toe. We are going to do this examination in the foot. Okay, we are going to pull the little toe, okay, laterally, then suddenly you're going to release it. On suddenly releasing that little toe, what is going to happen? You can see the greater toe. Okay, when and all you are telling it is a positive, the patient is having some neurological deficit. So when what are all the cases we are telling? When the greater toe or the big toe is dorsiflexing, right? When the big toe is dorsiflexing, you are telling it is a positive sign that some neurological impairment is there, right? The same way in Stranke sign also, when the little toe, yes, very good. So in a little toe, when you're pulling it and you're suddenly releasing it, you can see the dorsiflexion in the greater toe, right? Or the big toe. So when you see this dorsiflexion, it is a positive sign and it is relating that it is the upper motor neuron lesion, right? So in Babinski sign, what you're doing, you're just doing a scrolling, okay? You're just scraping the sole. When you scrape the sole, what will happen? Fanning effect, and if there is an upward movement of your toe, then you are telling it is a positive Babinski test. And that is relating that there is a what? Lesion. Right. So this is the concept behind your Stranke sign and your Babinski sign. So Babinski sign and Stranke sign, they are not totally similar, but they are all coming under the same component of analyzing the upper motor neuron lesions. Right. So next is your cornell sign. What does mean by cornell sign? So cornell sign is also the method to elicit your Babinski reflex, right? Corner sign is the method to elicit your elicit your Babinski reflex, where the inner cough, okay, the where you scratch the inner cough and it is going to cause the dorsiflexion of the big toe, okay, and it is going to tell you it is an upper motor neuron lesion, okay, upper motor neuron lesion related sign, right? Yes. So this is the concept behind this Uthoff sign, Lehmet sign, Stanky sign, and Cornell sign, right? So we'll go to the next question. Yes, a newly married couple recently moved to the high altitude place. Which of the following adaptation is not accepted after a month of staying there? So they're asking the newly married couple has recently moved to the high altitude place. And which of the following adaptation? Once they go to the high altitude place, their body will go for certain adaptations, right? So which of the following is expected after month of staying there? So they are staying there for a long period of time, right? So what will happen? Yes. So while studying about multiple sclerosis, it is very, very important to know about a triad. What is that triad, students? I hope you all are knowing about Charcot's triad, which is seen in case of your multiple sclerosis, right? Which is the combination of your nystagmus, okay, intentional tremor, and scanning speech. What are the components of your Charcot triad? Nystagmus, okay, nystagmus, intention tremor, and your scanning speech. Right? Okay. So this is your Charcot's triad and another important question. And many people started answering for this particular question also. A newly married couple, okay, recently moved to a high altitude place. So which of the following adaptation is not expected? They are asking what is not expected. Be very clear with the key points. Only one word is going to change the entire answer, right? They're asking which of the following adaptation is not expected after a month of staying there. So if a person is staying in a high altitude, okay, the PaO2 is going to fall. First and foremost is the PaO2 is going to fall. Right? The barometric pressure is going to get lowered, right? The air pressure or the barometric pressure is going to get lowered, right? So many people are answering, but be very cautious while answering, right? So I'm asking, which of the following adaptation is not expected after the month of staying there? Now, classically analyze your answer and tell me, which of the following is not expected? I'm not asking about expected factor. I'm asking about not expected factor. And the most important thing is chronically. For example, they are adapted. After a month of staying there, what is going to happen? What is going to happen, you all know. Here they are asking what is not going to happen. Yes, cardiac output becomes normal later. One student has given the answer. Saki. Yes, very good. See, increase in cardiac output, it is not a chronic effect of patient being staying in a high altitude. After days goes, the body will adopting and the cardiac output become normal. Okay, it will become normalized. Okay, acutely, it will be slight increasing, but later it will become normalized, right? So this is a very, very important feature. So this is how you have to categorize the MCQ, right? Adaptation, they're asking about adaptation. Adaptation has happened, but they're asking the not factor, except factor, right? Which of the following is not seen, right? Remember, so just we will have a quick recap. So whenever we are in a high altitude, the partial pressure of O2 is going to get increased, which means there will be a lower in the barometric pressure, right? So if it is going to happen, the compensatory adaptation will be happening in order to maintain the proper O2 delivery to the body, right? So in acute setting, what all you can see is, first is increase in pulmonary ventilation. Okay, first is increase in the pulmonary ventilation, right? Pulmonary ventilation get increased because of hypoxic ventilated response, right? Hypoxia is stated. So that's why pulmonary ventilation is getting increased via the peripheral chemoreceptors of carotid bodies, right? The next is the heart rate and cardiac output will be increased, right? This is the acute response. This is what you have to remember. This is the acute response, right? So next we are going to see the chronic response. For a long term, they are staying in that high altitude area itself. Okay, from weeks to months of adaptation, what all you can see, right? First is the patient RBC production will be increased. Increased RBC production stimulated by your erythropoietin in kidney, and you can see polycythemia also, right? Okay. So if increased RBC production is there, obviously the HB concentration is going to get increased. Increased HB concentration. Okay, secondary to polycythemia, HB concentration is also going to get increased. Then after that, what about your oxygen dissociative curve? Okay, what will be the shift you can see in your oxygen HB dissociation curve? You can see the rightward. Okay, your rightward shift of the curve. Okay, rightward shift of the curve. Yes, because of your erythropoietin polycythemia. Is very good. Erythropoietin from the kidney increases, which leads to polycythemia. Wait, shifting to right, Anshika, very good. So shift off your O2 dissociation curve to the right side will be there, right? Because of the increase in the 2,3 dpg in the RBC, in the RBC, which will lead to the dissociation curve rightward shift, right? So again, pulmonary ventilation will be also increased in chronic cases also. The capillary density is also going to get increased. Capillary density is also going to get increased. And the cardiac output, here is the classical feature which you're going to learn. the cardiac output normalizes. The cardiac output normalizes, right? So acutely, there will be an increase in cardiac output. Later, with chronic acclimatization, this cardiac output is going to get normalized. After months, in a chronic phase, it's going to get normalized. So the correct answer will be what? Increased in cardiac output. Increase in hemoglobin concentration, yes, we are going to see it. Increase in pulmonary ventilation also we're going to see. Increase in number of RBCs also you're going to see in case of chronic adaptation state. But in chronic adaptation state, cardiac output is going to not get increased. It is going to get normalized, right? So next MCQ. A patient who is presented to the emergency, okay, with a chest pain and dyspnea and diagnosed with STEMI, that is your ST elevated myocardial infarction, shift revascularization by thrombolysis is planned for her. Okay. Then what is the dose of streptokinase used? Now tell me, what is the dose of streptokinase which is used for this particular patient? Active students, put your answer in the chat box. Yes. See, what is streptokinase first? Streptokinase is a thrombolytic agent or a fibrinolytic agent, as you all know, right? This streptokinase is derived from what? Your beta hemolytic streptococci. Streptokinase is derived from your beta hemolytic streptococci. Right? Many people are answering A. Is it is correct? Many people are answering A. Is it is correct? Rakesh, Renuka, very good. These students are coming to the track. Yes. The correct answer is B, children. Okay, the correct answer is B. It's not A. 1.5 million units IV over 1 hour. Remember first, what is streptokinase? Streptokinase is a fibrinolytic thrombolytic agent, as you all know, right? And it is derived from beta hemolytic streptococci, right? This forms a plasminogen, activates the plasmin and degrades the fibrin clot. The ultimate action is what? It degrades the fibrin clot in the coronary arteries, right? The standard dose, don't make mistake in this. The standard dose is 1.5 million units IV over 1 hour. This is the correct answer. Don't confuse yourself, right? And that is the gold standard dose, and you have to definitely memorize this particular dose. Don't make any mistake in this. And the most important thing is, certain limitations and contraindications are there when you are planning to administer streptokinase to this particular patient. Remember, if there is a prior streptokinase usage within past 6 months, okay, prior streptokinase usage within past 6 months. So I have said you it is a bacteria-derived component, right? So if it is administered within 6 months, there is a lot of chances the antibodies can be formed against that, and it can lead to anaphylaxis. It can lead to anaphylaxis. So it is contraindicated. Look for scenarios in this question. If there is a scenario stating now only the patient has taken with the recent history of streptokinase intake and you are planned for this thrombolytic therapy. Okay, that's how they confuse you, right? So prior streptokinase used within past 6 months, which means there will be a lot of chances antibodies will be formed and anaphylaxis reaction will be possible if you're going to administer in this particular period, right? And another important thing, it's your beta hemolytic streptococci. So definitely if there is a recent streptococcal infection, it is contraindicated, right? Recent streptococcal infection, it is contraindicated. And if the patient is having active bleeding, recent surgery, or any hemorrhagic stroke, or uncontrolled hypertension of greater than 180 out of 110, So in those terms, in those conditions, we are not giving this streptokinase and it is completely contraindicated. And the dosage is very, very important to learn, right? It is B, right? Yes. So what is the basic difference between your STEMI and NSTEMI? ST elevated MI is your full thickness transmural infarct, as you all know. Okay, it is a fibrin rich clot. So we are doing fibrinolysis as we have planned for this particular patient. Whereas in non-ST elevated, it is not a full thickness transmural infarct, it is a partial thickness infarct. If it is a partial thickness infarct, what is going to be seen in ECG? You're going to see ST depression if there is a partial thickness infarct. Very good. So in case of ST depression you are seeing and it is a non-ST elevated MI, then it is a platelet rich clot. If it is a platelet rich clot, very good, Parvesh. If it is a platelet rich clot, fibrinolysis is what? Fibrinolysis is contraindicated. Very, very important pointer. Right? So these are the very, very important pointers that you have to definitely remember. Right? Yes. So next we'll go to the next MCQ. Which of the following is not the feature of Brown-Sequard syndrome? Very commonly asked MCQ. They're asking. Okay, they're asking about which of the following is not the feature of Brown-Sequard syndrome. See, in case of NSTEMI, okay, if the patient is a case of NSTEMI, okay, and we are telling NSTEMI means it's a partial thickness infarct, okay, it's not a full thickness infarct. So if it is a partial thickness infarct and you see the ECG finding of ST depression, okay, it is a platelet rich clot. Okay, so if it is a platelet rich clot, at that time we are not going to administer this fibrinolytic therapy, right? So this is the concept behind that. And let's come to the which of the following is not the feature of Brown-Sequard syndrome? Yes, many people have answered it correctly, like complete transection of your spinal cord. Brown-Sequard syndrome is the hemisection of your spinal cord. What is that? It is your hemisection of the spinal cord, which means either right half or the left half will be affected. Okay, right half or the left half is going to be affected. Half transaction is going to get affected and injured in Brown-Sequard syndrome. So the important characteristics which you have to remember is the patient will be having ipsilateral. Okay, if ipsilateral loss. Okay, of motor function, loss of vibration, touch, and proprioception. Right? So this is the specifically remember ipsilateral loss of motor and sensory function and contralateral loss of what? Pain and temperature. Right? Yes. Brown-Sequard syndrome, remember, only half of the spinal cord is damaged. If half of the spinal cord is damaged and we have lot of tracts, okay, your corticospinal tracts we have, your dorsal columns you have, your spinothalamic tracts we have good number of tracts which is innervating inside. So when because of this innervation, when half of the spinal cord is affected, hemisection is affected, the patient is going to have ipsilateral motor and sensory loss, right? Which means on the same side, the patient will be having motor deficit. Okay. And loss of vibration, touch, proprioception, awareness about my body will be lost at the same side. But the patient will be also having contralateral loss of pain and temperature. Right. So this contralateral loss of pain and temperature, which is because of the communication which is happening in the spinothalamic tract. Right. That's why you're seeing this ipsilateral motor and sensory loss and contralateral pain and temperature loss. Right. Very good. Right. So we are going to see about the next question. So during the clinical examination of the patient with a known history of rheumatoid, rheumatic heart disease, you notice a pansystolic murmur, heard best at the apex, radiating to axilla and back. See, streptokinase, as I said you, it is derived from your beta hemolytic streptococci, right? If it is derived from this bacteria, if the patient is having the history of streptokinase intake, okay, the injection has been given, within past 6 months, which means it is a bacterial component. Obviously, the antibodies will be formed against it. So if the antibodies are formed against it, what will happen? The antibodies will be there. Again, you're giving within 6 months, if you're going to re-administer streptokinase, what is going to happen? The patient's antibodies will be reacting to the streptokinase which you have given. So if that is happening, it will cause anaphylactic reaction, drug-related anaphylactic reaction, which is not good, right? So that's why it is contraindicated, right? So we are going to the next question. Many students have started answering correctly. Yes. So a patient, during a clinical examination of a patient with a history of rheumatic heart disease, and you notice a pansystolic murmur, and which is here best at the apex and radiating to the axilla and back, which of the following changes in the murmur would you expect to see? Would you expect to see in the patient if you made them to squat from standing position? A patient is a case of what? If he is having pansystolic murmur, what is the diagnosis here? Right? Yes. Tell me, what is the diagnosis? Pansystolic murmur is seen in which condition? Very good, very good, very good, Anshika. Anshika is clearing this time, right? Yes. Yes, tell me. Pansystolic murmur is seen in which condition? Pansystolic murmur is seen in case of your mitral regurgitation. Whenever you see a word regurgitation and stenosis, you have to remember this. Right? So, if you see a word regurgitation is problem in closing. Stenosis is problem in opening, as you all know. When there is a mitral regurgitation, you can see this pansystolic murmur, which you can hear best in the apex, which you can see always radiating to the axilla. Okay, axilla and back. Right. So here, this mitral regurgitation, what it will do? Mitral valve is present between your left atrium and left ventricle, right? So it is present between your left atrium and left ventricle. So what will happen? The left atria and left ventricle is there, and in between the mitral valve is there. If mitral valve is regurgitating, the problem is in closing. What will happen? The blood, okay, during the systole, what will happen? The blood will be pulled back to the left ventricle from the left atrium. Okay, a lot of blood will be back flowing from the left atrium to the left ventricle itself. Right? So this is the reason you are hearing this pansystolic murmur. Right? So here, when the patient, I'm making the patient to squat in a squatting position. So when I'm sitting in squatting position, what will happen? In squatting position, venous return, what it will become? Venous return will become higher, right? Preload become higher. And left ventricular filling will also be getting higher, right? So primarily what will happen? If venous return is higher, which means a lot of blood is coming back to the left atrium, and due to mitral regurgitation, mitral valve is not closing properly, and lot of blood is again overpulled into your left ventricle. Right? What is meant by preload? Preload is the volume of pressure in the ventricles at the end of your diastole before contraction. Right? Yes. So here what will happen? A lot of blood is pulled back into the left ventricle again. So again, if the lot of blood is pulled back into the left ventricle, you can hear an increased amount of pansystolic murmur. Right. On the other hand, squatting can also causes increase in the systemic vascular resistance. So if there is an increase in systemic vascular resistance, it is going to increase the afterload also. It's going to increase the afterload also. If the afterload is also increasing, obviously, the regurgitant volume through the mitral valve is going to get higher and higher, and the murmur is going to get increased and increased. Right? So this is the concept where during squatting, this murmur is going to get increased because of both increase in preload and afterload, left ventricular filling, and the venous return is going to be higher. The systemic vascular resistance is going to be higher. All are going to contribute for increased in the murmurs sound, right? So increased is the answer, right? So now tell me, in what are all the cases during squatting, the murmur decreases? In what are all the cases during squatting, the murmur decreases? Remember, in case of your HOCM, hypertrophic obstructive cardiomyopathy, when you ask the patient to sit, at that time the murmur decreases, right? The murmur decreases. After, in other conditions such as your mitral regurgitation, in aortic or mitral stenosis, when you're going to place the patient in squatting position, what is going to happen? The murmur is going to get increased, right? So this is very, very important, right? You have to remember this particular concept. Yes. So the next question. What is the most common cause of chronic kidney disease? A very, very easy question. Suddenly, I think you people will be answering for this question. What is the most common cause of chronic kidney disease? Yes, obviously, in developing countries like India, the most common cause, okay, which is accounting 35 to 40% cases of of CKD or associated with your diabetic nephropathy, and diabetic nephropathy is leading to end-stage renal disease, right? So why diabetic nephropathy is leading to CKD to the greater extent, as you all know, when there is an increased amount of glucose in your body, right? This is going to create a non-enzymatic glycation. Okay, what is going to happen? Non-enzymatic glycation in the tubules. And that is going to damage your glomerular basement membrane to the greater extent. Okay. And what happened? What is going to happen? And that is going to damage the glomerular basement membrane. And it is going to thicken the glomerular basement membrane even more. And it is going to expand the mesangial cells also. Okay. So when these things are happening simultaneously, obviously, the patient will be going for glomerular basement membrane damage, and which leads to glomerular hypertension. And you can see the patient will be presenting with proteinuria and leading to CKD, right? So here, diabetic nephropathy is the most common cause of your CKD. What is the second most common cause? Obviously, it is your hypertension. Second is your hypertension. First in India and USA, it is your diabetic nephropathy. Second is your hypertension. Glomerular nephritis, which is also a leading cause in young patients, okay, in developing countries. Specifically, glomerular nephritis also. We have various classification in glomerular nephritis also. So IgA nephropathy. IgA nephropathy is closely associated to cause chronic kidney disease, where the immune complexes are going to get accumulated in the glomerular basement membrane and leading to the impaired function of your glomerular, which means the filtration process will be impaired, right? So adult polycystic kidney disease is not having that much close association with the CKD's cause, right? Remember this, diabetic nephropathy is first globally and in India, right? Hypertension is second, right? Glomerular nephritis and other things comes later only. In glomerular nephritis also, they're going to ask you specifically, then your answer should be IgA nephropathy, right? Yes. So the next question. A 45 years old chronic alcoholic male developed dyspnea, fever, and hypotension after being administered 2 units of fresh frozen plasma. Oxygen saturation of 88%, which is less, and bilateral lung infiltrates, key pointer, were seen in chest x-ray, and he was diagnosed to have transfusion related acute lung injury. They have given you, yes, very good, 6 hours is the correct answer. Very good, Anshika. See, transfusion related lung injury, they have given you the diagnosis also. What is the duration within which TRALI occurs after transfusion? Yes, what is the correct answer? Many students have answered it correctly. Yes, C is the correct answer. This is a very, I'm expecting definitely questions from Trally and Taco in this paper, right? Definitely expecting MCQ from this Trally and Taco in your upcoming not set, or any question related to transfusion related reaction that is very commonly asked, right? So it is very important to know about the differentiation between this Taco and Trally. Okay, let's learn it very clearly. So here you have to remember, he is a chronic alcoholic male patient developing dyspnea, fever, and hypotension. And after being administered with 2 units of fresh frozen plasma, he is developing these symptoms where the oxygen saturation is falling to 88% and bilateral lung infiltrates because of hilar enlargement, which is seen in chest x-ray. And they have also given you the diagnosis. The patient is a case of transfusion related acute lung injury, right? So whenever you see a word transfusion related acute lung injury, the mechanism is because of your anti-HLA antibodies, anti-HLA antibodies or your anti-HNA antibodies, or specifically you remember about anti-HLA antibodies. This anti-HLA antibodies is activating the neutrophils. So this is causing cross reaction and alveolar damage. This is causing cross reaction and alveolar damage is happening, right? So when this particular damage is happening, okay, because of this anti-HLA, okay, the recipient neutrophils are getting activated and they have started working on this particular blood component, and this will cause a capillary leak which leads to pulmonary edema. This causes capillary leak and causes pulmonary edema. Remember, in TRALI, transfusion related acute lung injury, it is a non-cardiogenic pulmonary edema. It is a non-cardiogenic pulmonary edema, right? And what will happen? The most important correlation you have to remember is in alcoholic patient, this TRALI can be triggered more prominently. Okay, recently he has consumed alcohol or surgery. This can even worsen this particular concept of this. Yes, very good afternoon, Mumtazir. Okay, so there is a lot of chances this can be associated, like all chronic alcoholisms, surgery can be the immediate factors where TRALI occurrence can be higher, right? So once the patient is getting a TRALI, okay, you can see the oxygen saturation is falling and the patient will be getting a non-cardiogenic pulmonary edema, right? And in most of the cases, the patient may present with fever. Patient will go for hypotension. Okay, these are the classical features of TRALI. Okay, bilateral infiltrates and hypoxemia, as we have all seen this in the question itself. And hypoxemia, where your oxygen saturation is falling. Right. So what is the management of this TRALI? First is to immediately stop the O2. So immediately we have to stop the transfusion. Then we have to start the oxygen administration. Okay, if required mechanical ventilation, we can give that also. And the most important thing is we are not administering any diuretics in the management of TRALI, but diuretic is an important management in case of your TACO, right? So on the other hand, we are going to discuss about TACO. What is TACO? Transfusion associated circulatory overload. What is TACO? Transfusion associated circulatory overload, right? So here, what are the classical features you can see? Here you have seen hypotension. Here you will see hypertension. Okay, fever may not be present. Okay, and pulmonary edema will be there. Pulmonary edema, which is cardiogenic. Because of excessive volume overload. Okay. Okay, TACO has cardiogenic involvement, very good. So because of excessive transfusion, okay, the cardiac overload is happening, and that will lead to this what? Cardiogenic pulmonary edema or this transfusion associated circulatory overload. TRALI is because of anti-HLA antibody mediated reaction where the neutrophils are activated and they are causing the capillary leak and damage, right? But TACO is purely because of volume overload. TACO is because of what? Volume overload, and thereby the patient will be going for cardiogenic origin pulmonary edema. Okay, the pulmonary edema which is happening is because of the cardiac related correlation, right? Yes. So next, what are the important components you have to study is hypertension is a classical feature. Pulmonary edema, which is cardiogenic oriented, that is an important feature. And the next important feature is you can see an elevated BNP. Your BNP level will be elevated. Why? When, in what cases BNP level will be elevated? When the ventricles are stretching too much, the BNP level will be getting elevated. That is a classical differentiator which you have to use. BNP will not be elevated in case of TRALI, but BNP will be elevated in case of TACO, because TACO is a circulatory overload related problem. When there is a circulatory overload, the ventricular enlargement is possible. Ventricular stretch or ventricular stress can lead to increase in BNP levels. So BNP level rise or elevation is a classical feature of your TACO that you also have to remember. So what is the management of TACO? And what duration TACO occurs? TACO is also occurring in 6 hours only. Okay, both TRALI and TACO both occur in 6 hours. Okay, within 6 hours. To be very classical, remember, within 6 hours, TACO and TRALI happens. But they are two differentiated cases. So you have to remember that differentiation, right? So coming back to the management of TACO, again the same. We have to stop the transfusion. Okay, and you have to give diuretic. Diuretics. Okay. Yes. Stopping or slowing the transfusion. Okay. If there is no visible hyperreaction, we can slow the transfusion also because it is a circulatory overload, right? So here we are going to administer diuretics, the important drug. Okay. The important drug is your furosemide we are using as a drug. But in case of your TRALI, we are not using furosemide. This is a classical differentiation which you people have to remember, right? So other reactions are what? What is your acute hemolytic transfusion reaction? It is because of your ABO incompatibility, which happens within minute to hours, right? So that is your acute hemolytic transfusion reaction. Then we have your febrile non-hemolytic transfusion reaction, which is because of cytokines in the blood products. So that's where you are using leukoreducers, leukoreduction drug, leukoreductants. In case of your febrile non-hemolytic transfusion reaction, we are using leukoreducers in order to reduce this cytokine effects, right? Allergic and urticaria, this happens within minutes to 1 hour. Again, remember acute hemolytic reactions, allergic reaction, this happens within minutes to what? Minutes to hours. Your febrile non-hemolytic reaction, what is the duration? It happens between 30 minutes to 2 hours. 30 minutes to 2 hours. That you have to remember. Anaphylaxis. Anaphylaxis happens within seconds. Anaphylaxis happens within seconds. Anaphylaxis are IgA deficiency related reactions, right? Where you can see hypotension, bronchospasm. Okay, we have to stop the transfusion immediately, and we have to start the what? Epinephrine administration. Yes. So next we will go to the next question. Water hammer pulse is seen in which condition? Yes, answer me in the chat box. Water hammer pulse is seen in which of the following condition? Very good. Water hammer pulse is seen in case of your aortic regurgitation. Water hammer pulse or Corrigan pulse. Okay, that is classically seen in, very good, B. Everyone is so much in fingertip about this. So it is seen in case of your aortic regurgitation, right? So what are the other things you can see in case of aortic regurgitation? Other signs. Tell me what is de Musset sign? What is de Musset sign? Head nodding. Head nodding with each heartbeat. So what is the expansion of, what is the better explanation of this Corrigan pulse or water hammer pulse? Remember, it is a rapid rise and collapse of your radial pulse. Rapid rise and collapse of radial pulse. Right? What is Quincke's sign in case of your aortic regurgitation? Okay, head nodding, bobbing of head. Very good. What is Quincke's sign? What is Quincke's sign? Any students? Capillary pulsation seen in nail buds. Capillary pulsation seen in nail buds. What is drowsy sign? These are all coming under your, very good. What is drowsy sign? What is drowsy sign? Femoral arterial murmur with a light compression you can hear. Okay. Femoral artery murmur with light compression. We have even more signs in aortic regurgitation. What is Muller's sign? What is Muller's sign? Pulsation of your uvula. Very good, very good. Pulsation of. Whenever they want to ask you memory-based questions, okay, they can ask you like this. Pistol shot sign. What is that? Pistol shot sign or Trowbridge sign. This is otherwise known as Trowbridge sign. So what is that? Many people have already said about this sign. What is that? Pistol shot sign or your Trowbridge sign, that is booming sound over your femoral artery. Okay? Booming sound over femoral artery. Okay? Landolfi sign. What is Landolfi sign? What is Landolfi sign? What is Landolfi sign? Anybody in the chat box? Landolfi sign is an alternate constriction and dilatation of the pupil. Okay? Alternate constriction and dilation of pupil. Right? Landolfi sign. Very good, very good. What is Hill sign? Hill sign. Hill sign is popliteal systolic pressure will be greater than your brachial by 20 mm of Hg. Right? Your popliteal systolic pressure will be greater than systolic pressure greater than 20 mm of Hg okay, by brachium. So these are all the signs which is available for your aortic regurgitation. Okay, so these you have to remember. So coming back to aortic stenosis, what finding you will be seeing in aortic stenosis? In aortic stenosis, you can see pulsus parvus et tardus, as you all know, right? In aortic stenosis, you can see ancotic pulse or your pulsus parvus et tardus, right? So this is all about your this question. Let's go to the next question. Tell me, for an MDRR-TB, okay, for an MDRR-TB, which means multi-drug resistant and rifampicin resistant also. RR means what? Rifampicin resistant TB. What is the indication for the short course bedaquiline? Come on, get ready with your answers. Yes, in TACO, we will get cardiogenic pulmonary edema. In TRALI, we won't get cardiogenic related pulmonary edema. Yes. Coming back to the MDR-TB question, MDRR-TB, which means multi-drug resistant plus your rifampicin resistant TB. What is the indication of short course bedaquiline? Yes, resistance to rifampicin and sensitive to fluoroquine. So at that time, we are going for this what? Bedaquiline, short-term therapy or short-term course of bedaquiline. So resistant to rifampicin and sensitive to fluoroquinolones, right? So what is drug sensitive TB? Drug sensitive TB means it is sensitive to all first line drugs, right? That is drug sensitive TB. Okay. What is RRTB? RRTB is rifampicin resistant TB, right? MDR-TB, multi-drug resistant TB, which is resistant to rifampicin and isoniazid as well. That is multi-drug resistant TB. What is mean by pre-XDR-TB? Pre-extensive drug resistant TB means it is the case of multi-drug resistance and resistance to any fluoroquinolones. Resistant to any fluoroquinolones, we are seeing this MDR-RR-TB, right? Which means we are having rifampicin resistance, and so that fluoroquinolone sensitivity is the primary reason we are starting with the short-term bedaquiline, right? And next is XDR-TB. XDR-TB is where you have resistance to like MDR component such as rifampicin, isoniazid, you're resistant. Fluoroquinolones also you're resistant. And at last, bedaquiline or linezolid also the patient is resistant. Then you're telling it is a extensively drug-resistant TB or an XDR-TB, right? Now coming back to this particular question, what are all the indications for a short course bedaquiline? As per your National Tuberculosis Elimination Program, what are all the indication of your short course bedaquiline? First and foremost, either the patient should be an rifampicin resistant TB or a multi-drug resistant TB. Multi-drug resistant TB means what? It is rifampicin and isoniazid. Okay, resistance to any rifampicin or isoniazid, right? So, and if the patient is a fluoroquine sensitive strain, he is going to be eligible for this bedaquiline short course therapy. What is the expansion of your BPAL? What is the expansion of your BPAL? B stands for your bedaquiline. B stands for bedaquiline. And P stands for your pretomanide, right? B stands for your pretomanide. And L stands for your linezolid. L stands for your linezolid. Very good, very good. Very good. Pretomanide and linezolid. Right. If fluoroquinolone resistant is there, okay, if you see here, it is fluoroquinolone sensitivity. If fluoroquinolone resistant is there, So what we are doing, the same B-PAL along with moxifloxacin, along with what we are giving? A longer regimen, along with moxifloxacin. Okay, children, now tell me one of the important MCQ point when you study about bedaquiline. Bedaquiline causes QT prolongation. What is that? Bedaquiline is a potent drug which can cause QT prolongation. A second line anti-tubercular drug, as you all know. And moxifloxacin, remember, moxifloxacin causes maximum QT prolongation. Moxifloxacin causes max to max QT prolongation will be caused by your moxifloxacin, right? This is a classical point you people have to remember for your examination. Bedaquiline is a potent drug which can cause QT prolongation, right? Moxifloxacin is a drug which causes maximal QT prolongation, right? So it is very, very important to see or monitor ECG. Very good. To monitor ECG while administering these particular drugs, right? Yes. Next, we'll go to the next question. A patient with multiple myeloma has elevated serum M protein component, but the dipstick of urine protein is negative. Which of the following class of immunoglobulins constitute a major part of this component? Come on. A patient with multiple myeloma, right? And she's also having an elevated M protein component, but the dipstick of urine protein is showing negative. Why? And which of the following class of immunoglobulin is constituting a major part of this component? First of all, what is your multiple myeloma? It is a malignant proliferation of your plasma cells, right? Malignant proliferation. Okay, many students started answering correct. Proliferation of plasma cells. Specifically, this M protein will be there. And some components of light chain, which includes your kappa and lambda, are all multiple times they are proliferated in the body, right? So here the most important thing is, well, while talking about light chain, remember kappa and lambda. Okay, kappa and lambda. Remember here where you can see this Bence-Jones protein, right? Here where you can see this Bence-Jones protein because of this only. Very good. B. Very good. Okay. IgG is the correct answer. That is the most common M protein, which is seen in case of your multiple myeloma, which is seen at the rate of 55 to 60%. Right. So what is the second most common? Second most common is IgA. Second most common is your IgA. Okay. And light chains is associated with your Bence-Jones protein, which you can see. Very good, Anshika, very good. So IgD, will it be seen? It is rare, but it is associated with a very worst prognosis, right? And what about IgM? It is not typically associated with your multiple myeloma, that you have to remember, right? So why we are not seeing this particular, it is not detected in the urine dipstick. So this M protein is having a heavy component. Okay, it is having a heavy chain, which is very large. This M protein related chains are very heavy. Okay, so this is very large and it cannot be filtered by your glomerular filtration, right? As you all know, this glomerular basement membrane, it is a very delicate membrane where the podocytal activity will be there. What is going to happen there? It is going to remove, okay, filter out small molecules such as water, electrolytes, urea, create, but it is going to stop the middle molecules also. Okay, so medium-sized molecules such as your proteins, everything will be sent back. RBCs will be sent back, larger molecules like RBCs. So like that, only limited amount of molecules can enter into those particular glomerular basement membrane and can be filtered into the urine. So since this M protein, which is mediated by your IgG, is a large and heavy chain, okay, it's a combination of heavy and large chain, so that cannot be filtered with the urine. So that's the reason you cannot see this in the urine dipstick, right? So remember this particular component, right? So urine marker, you can see the Benz-John protein, the light proteins, which is the light proteins, because of light chains, they can be filtered out in the urine, but they cannot be detected in dipstick. They cannot be detected in dipstick, but they can be detected while you're doing this. What? While you're doing this urine marker analysis. Yes, very good. Learning about crab is very, very important. Most common M protein in multiple myeloma. Close your eyes and remember about IgG. Next is crab concept. What is this crab concept in your multiple myeloma? C stands for hypercalcemia, right? C stands for what? Hypercalcemia. R stands for your renal failure. Okay. And B stands for your, sorry, A stands for your anemia and B stands for your bone pain. Okay, these are the classical features you can see in case of your what? Multiple myeloma. This is a very, very important concept, right? Yes. The next question, will go a little bit fast. Yes, very good, Anshika. So which of the following laboratory investigation finding is unlikely to be seen in patient with hemolytic anemia? Come on, give your answers. Which of the following finding is unlikely seen? They're asking unlikely seen. Yes, answers. Increase in serum indirect bilirubin. Some students are answering. Yes, I'm waiting for the correct answer. Unlikely seen. You cannot see bilirubin in urine. Very good. Presence of bilirubin in urine, you will not be seen. No bilirubin in urine in case of hemolytic anemia. Why? In case of hemolytic anemia, your unconjugated bilirubin is bound to albumin. Your unconjugated bilirubin is bound to albumin. So now it is becoming what? Water insoluble. Now it is becoming water insoluble. So if it is becoming water insoluble, it cannot be filtered by the kidney. It cannot be filtered by kidney. Very good. Many students are answering correctly now. So when it cannot be filtered by kidney, okay, obviously you're not going to see it in the urine, right? So that is the concept between. Yes, increase in serum indirect bilirubin will be seen in case of your hemolytic anemia. Okay, RBC destruction will be there, which is going to increase the unconjugated, which means indirect bilirubin level. Okay, unconjugated bilirubin will be higher. Okay, so you can see all this increased serum indirect bilirubin level, increased fecal uroglobulin, and your increased urinary uroglobulin, because simultaneously, once this mechanism is happening, everything can be seen, but you cannot see presence of bilirubin in urine in case of your hemolytic anemia. That is the concept behind this, because it becomes water insoluble because of bonding to albumin, right? Now tell me, what is the crystal given here? What urine crystal is shown here? Image-based MCQ, high yield question. Identify the urine crystal given here. I'm waiting for your answers. Either it is calcium oxalate, calcium phosphate, uric acid, or cystine zone. See, this is an envelope kind of stone, right? It is showing an envelope shaped, right? It is, you can see it is like an envelope. Okay, it is like an envelope. Yes. Envelope, if I'm telling envelope, you are just answering. But before that, you people should answer. It's a calcium oxalate stone. Oxalate stone. Okay, it's a calcium oxalate stone that is going to show you an envelope or octahedral shape, or otherwise known as dumbbell shape. Okay, remember everything is same. Dumbbell, envelope, everything is indicating your calcium oxalate stone. What about your uric acid stone? Rhomboid or needle shaped stones. Okay, rhomboid or okay, Noor, I'm considering you. Sorry. Okay, your rhomboid. Okay, your rhomboid or needle shaped stone, or your what? Calcium phosphate stones. Sorry, this is for not calcium phosphate, this is for uric acid. Okay, pointed rhomboid, okay, or needle shape is for what? Uric acid, it is not for calcium. Okay, now you should remember even more with clarity, right? Rhomboid shape or needle shaped, okay, or seen in case of your uric acid stones. Okay, or seen in case of your uric acid stone, it's an, yes, it is an uric acid stone. So what about calcium phosphate? Calcium phosphate is amorphous kind of stone. Cystine stone, hexagonal, many people have answered. Right? This is a classical feature you have to remember. Uric acid is diamond or rhomboid shaped stone. People have to remember. Cystine stones are hexagon in shape, and uric like calcium phosphate or amorphous in nature. Right? So this is a very, very important thing. And what about coffin lid shaped? Coffin lid shape is seen in which? Coffin lid shaped stone. What is that? Coffin lid shaped stone. That is your, very good. That is your struite stone. Okay. Struite stone shows coffin lid appearance. Right? What is the most common kidney stone? What is the most common? Most common is your calcium oxalate. Most common is your calcium oxalate. Okay. 75 to 80% of the stones or what? Calcium oxalate stone, dumbbell shaped, envelope based stones. Right? Yes. What is radiolucent on X-ray? Only stone which is radiolucent on X-ray, that is uric acid stone. Only stone that is radiolucent. Okay, that is your uric acid stone, right? Yes, calcium oxalate is a most common. Coffin lid is seen in case of your struite stone. Okay, stagon callus, that is indicating your what? Coffin lid shaped stones. And this is like alkaline urine will be there. And when you tell about staghorn callus, which means infectious kind of stone, infectious stone, right? The next question. A 62 years old man who has a history of diabetes, hypertension, and hyperlipidemia, now present with left hemiparesis without any speech problem. Left hemiparesis without any speech problem. His symptoms resolve while he is being evaluated. Okay. So suddenly what happened? The patient is getting good and his symptoms are resolved. Which of the following statement about this, about his condition is correct? Come on now, tell me the answer. First, tell me what is the diagnosis of this question? A 62 years old man who has a history of diabetes, hypertension, and hyperlipidemia, and now present with left hemiparesis without any speech problem. Suddenly, his symptoms resolved while I'm evaluating the patient itself, his symptoms is getting resolved. Which of the following statement about his condition is correct? Many people are answering D. Yes, the diagnosis is anyway. The diagnosis is transient ischemic attack. The diagnosis is transient ischemic attack, as you all telling. Right. The sudden focal neurological deficit and fully resolve within 24 hours. Right. The sudden focal, what is TIA? Sudden focal neurological deficit. Okay. Which resolve within 24 hours. Which within 24 hours. The risk of stroke highest in the period immediately following a transient ischemic attack. Well and good. TIA warning is there. Okay, transient ischemic attack, post-transient ischemic attack, we are suspecting the patient is going to have what? A stroke risk. Okay. So risk of stroke after 48 hours of TIA is 3 to 10% chances are there. Right. So we are using this ABCD score also for that. Right. What we are using? So you are using this ABCD scoring and the correct answer is what? D only. Right. The risk of stroke is higher. Yes, very good. The risk of stroke is higher. Once the patient is going to go for transient ischemic attack, that is a sudden focal neurological deficit, okay, which is resolving within 24 hours. Suddenly, while I'm evaluating the patient itself, the patient got resolved, right? So you're suspecting there is a lot of chances the patient will get a stroke attack, right? So you have to remember within 48 hours, the risk is 3 to 10%. Within 48 hours. If it is going for within 7 days, okay, within 7 days, then you're telling the risk can increase for 5 to 15%. And if it is up to 90 days, the risk of getting stroke will be staying for 20%. Right. Here we are using this A, B, C, D, C, D to score, right? Where A stands for your age, B stands for blood pressure, and C stands for your clinical features such as unilateral weakness as it is given in your question. And D stands for duration, which is going to be greater than or equal to 60 minutes, or the duration is 10 to 59 minutes. So based upon that, you are going to calculate this risk score. Diabetes is also one of the component. We are going to calculate the score, how much risk the patient is going to have for stroke. So the interpretation is very important. If the score is 0 to 3, okay, your A, B, C, D2 score is 0 to 3, then you are telling it is low risk. Okay, when the score is going to 4 to 5, then you are telling it is a moderate risk. Okay, when the score is going for 6 to 7, you are telling high risk. Telling it is high risk. So this is a very, very important concept. Again, you have to remember. So the risk of stroke is highest in the period immediately following a transient ischemic attack. Yes. Come on. Now we will go to the next question. Yes. What is the flow of current? Arrange the following in the right sequence of cardiac excitation. beginning from the depolarization of the ventricular muscle? Yes. So how the current sequence is going, following from the beginning of the depolarization of the ventricular muscle. Remember, step 1, ventricular depolarization sequence. Yes, many people have answered correctly. Correct answers, correct answers. I want correct answers. See, step 1 is first is ventricular depolarization. So ventricular depolarization, after that, the left side of your interventricular septum depolarizes first. First, which is depolarizing? Left side. Left side interventricular septum is depolarizing first. Right? So the left bundle branch, the septal fascicle innervates the left septal surface and the current is passed. After that, it will go to the right side. Okay, after that, it will go to the right side. C is the correct answer. Yes. Yes, for repolarization, I'm asking. Sorry, for depolarization, I'm asking. Right? So ventricular depolarization sequence. First is the left side interventricular septum. Okay, followed by to your right, then it will go for the apex. Activation travels to your apex. So apex of the heart, down via the bundle branches and the Purkinje fibers, it is going to the apex. Then finally it will go to your AV group where the atrium and ventricles are connected. Okay, distinct feature, right? So the basal part of the ventricle depolarizes last. Yes. Left side happens first, then it goes to right side, then the apex, then the AV group. Right? This is very, very important to remember. Okay. So this is the normal QRS axis, how this QRS complex is forming. Okay, Q wave. Your Q wave is indicating your septal depolarization. Your Q wave is indicating septal depolarization. That has to be definitely remembered by you people. Right? So what is the normal PR interval? What is the normal PR interval? The normal PR interval is 0.12 to 0.20 seconds. Right. So in what cases this PR interval is going to get reduced? In what cases PR interval is going to get reduced? When the patient is going for heart block. Okay. Yes. When the patient is going to go for heart block, first degree heart block, the PR interval is going to get reduced. Right. So in what cases you can see a progressive lengthening of PR interval? Progressive lengthening of your PR interval will be seen in case of your second degree type 1 heart block. Constant PR interval, okay. Constant PR interval I'm writing here, constant PR interval, but drop in QRS. Drop in QRS, second degree type 2. No association between P wave and QRS, third degree or complete heart block. Right? An important MCQ pointer. The next question. A 45 years old known diabetic patient present with carpal tunnel syndrome, which muscle is likely to be affected or paralyzed? Come on. What is carpal tunnel syndrome? It is the compression of your median nerve. Okay, compression of your median nerve, as you all know. Median nerve innervates to your lobe muscles, right? It is very, very important to know this. Here, they are asking which of the muscle is likely to be affected or paralyzed. So here the concept is carpal tunnel syndrome. So we have to target the muscles which are innervating the medial nerve. Okay. So medial nerve is affected here. Yes. Many people have given the correct answer. Yes, the correct answer is your opinus pollicis. Okay. Your opinus pollicis is the correct answer. Along with opinus pollicis, we have others also, right? I have said you about LOF, right? LOAF. Remember, O stands for your, just now we have seen that is your opinus pollicis. L stands for what? What does L stands for? Come on. L stands for your first and second lumbricals. L stands for your first and second lumbricals innervate into medial nerves, right? Sorry. Yes, lumbricals. A stands for, here it is given adductor pollis. But in case of median nerve, remember it is abductor pollicis. Right. F stands for your yes. What does F stands for? Very good. Abductor pollicis. So you have to remember the differentiation between your abductor pollicis and adductor pollicis. Right. So this is very, very important aspects you have to study. Right. So if you talk about this adductor pollicis, 3,4 lumbricals, palmar introitus, these are all related to ulnar nerve. Okay, these are all related to ulnar. Remember, I'm writing in a different color. These are all related to ulnar nerve innervates. Okay, and these are all indicating your median nerve along with your opinus pollicis. Right? Yes. So next we will go to the next MCQ, the last MCQ of the series. A patient is present with pain in multiple joints involving both hand and knees over 2 months of duration. Her investigations revealed elevated ESR and C-reactive protein. ESR means erythrocyte sedimentation rate, and CRP is your C-reactive protein, right? So her investigation reveals so, and with negative rheumatoid factor. So the RA factor, okay, the rheumatoid factor or the RF factor is negative here. Okay, this is a seronegative rheumatoid arthritis case. This is a seronegative rheumatoid arthritis case. Right. Her blood showed presence of anti-CCP. What is anti-CCP? That is your anticyclic citrullinated peptide antibody, right? What is that? Anticyclic citrullinated peptide antibody. Peptide antibody. Right. So which of the following joints will likely to be sparred? Which means which of the particular joint will not be most affected? That is the question. So obviously that is your DIP, as multiple people have given it. So DIP, that is your distal interphalangeal joint, is the joint which is not affected that much, because you know rheumatoid arthritis specifically affects the synovial membrane where pannus formation will be there, right? So in the distal interphalangeal joints of the fingers, we have a different synovial structure where it is not that much good area for rheumatoid arthritis to play, right? So that's where this particular joint is sparely involved in the rheumatoid arthritis, that you people have to remember, right? So DIP involvement, if you're telling DIP is involved, okay, if I'm telling your distal interphalangeal joint is involved, then what will be the case? Which means it can be psoriatic arthritis or osteoarthritis or gout. Okay. If DIP is involved, it can be psoriatic arthritis or osteoarthritis. Okay. Or it can be a gout. Right? This is the important feature that you people have to remember. So yes, now we have come to the conclusion of our class. So it's a very long class, and sorry for this much long dragging class, right? So we have came to end of our class. I wish you all a very best for your upcoming NORCET examination, right? Very good. Still answering, very good. So I wish you all the best for your upcoming NORCET examination. All your hard work is going to definitely pay off. Okay. Be very confident. Okay. Believe in yourself before going and seeing the questions. Okay. Definitely success is in your hand. Okay. Apart from everything, the close thing which I want to tell you is believe in yourself. Like you have to strongly believe that I can do it. I'm the person for it. This time I'm sitting in AIMS Delhi. This time I'm sitting in AIMS Madurai, right? You have to fix it before you're going, right? I hope this session was really useful for you people, and I want you to share your inputs about the session. And if you want to connect with me, you can connect with me with this Instagram ID, Nursing with Priya Balan. Your queries will be answered there, right? And thank you so much for watching. Bye-bye. All the best for your examination. Take some rest after the class and start your preparation. Thank you. Soon it will be conducted, dear. All the examinations, mock test will be conducted soon. Okay, we can expect this thing soon.